Good evening, dear colleagues, and a very warm welcome to today's special meet of API Kochi in association with Ernakulam District TB Center. TB preventive treatment and latent tuberculosis infection. That's a topic or subject of discussion. It assumes important because it is estimated 1/4 of the world's population is infected with tuberculosis. So the topic is of vast importance to all practicing clinicians. To deliberate on this subject, we have Dr. Sharath G, who is the District Tuberculosis Officer and AIDS Center, Ernakulam. And to chair the session, we have Dr. G. Manoj, who is the Senior Consultant Physician at Ernakulam General Hospital. Now, may I invite Dr. G. Manoj to take over and initiate the proceedings? Thank you.
Thank you. Thank you, Radhakrishnan sir.
Thank you, Manoj. Yeah.
Good evening. Good evening, seniors and my dear colleagues. Am I audible?
Yes, sir. Yes, sir.
Okay.
You're very much audible.
Yeah. We all know what is latent tuberculosis. We are all, everybody is inhaling tubercle bacilli every day. But what happens to this tubercle bacilli? If you have got a very healthy immune system, these tubercle bacilli are prevented from multiplying in our body. So active tuberculosis disease happens only if your immune system is defective. But if the exposure is very high, as in if you are in a close contact with a TB positive patient in your family, these tubercle bacilli remain dormant in our body. Whenever our immune system gets defective, as in many situations like HIV infection, uncontrolled diabetes mellitus, then inadvertent use of steroids, use of biologicals as in rheumatoid arthritis, undernutrition, chronic alcoholism, uncontrolled diabetes mellitus. In all these situations, the immune system becomes defective. So the dormant bacilli becomes active, start multiplication in our body and leads to an active TB disease. The government of India has started a TB eradication program around 2 years back. The aim was to eradicate TB all over India by the year 2025. While running this program, it was seen that not the active part of the disease was the disease control program was detection of active tuberculosis cases by sputum post examination. But while running this program, it was decided that to achieve this eradication program, we have to eliminate the latent tuberculosis also. So now the government has come out with a new program to detect latent tuberculosis patients. These latent tuberculosis patients, they can become positive for tuberculin skin test or newer methods like interferon gamma based assay like IgRA. So to introduce any program to eradicate tuberculosis cannot become successful without the support of the physicians. So we should know who are all to be screened for latent tuberculosis. What are the medicines to be used in latent tuberculosis treatment? How long to be given? What are the side effects? What is the special what happens in special situations like pregnancy? To enlighten us regarding all these factors, we have with us today Dr. Sharath G. He is the District TB Officer. He belongs to Todupuzha and he graduated from Bangalore Medical College. Ever since he joined the health service, he was very active in all the government programs. He was the District Program Manager of National Health Mission at Idiki before assuming the present job as District TB Officer. He has attended and various programs and seminars and regarding the tuberculosis control programs, and he is a doyen in this field. So he is the apt person to enlighten us regarding this new program of Government of India. I invite Dr. Sharath. Please take over the meeting. Okay. Thank you.
Very respected seniors, Manoj sir, friends and colleagues. Thank you for inviting me to this program. As Manoj sir has said, this is a new program which has been piloted in Kerala. LTBI infection management with testing. What they do in North India is if the patient is having TB, so all their households are being administered with TPT. So API, IAPSM, APCCM, all the associations unitedly told, no, we cannot do that, we have to do the test, then only we can treat. So Kerala is piloting IGR test, interferon gamma release assay test, otherwise called as quantiferon gold or TB gold, which is now used for treating or detecting latent TB infection. Two things, TB infection and TB disease. As Manoj sir was saying, we all have the bacilli within us. Until and unless our immunity is down, that bacilli will be staying within us without causing any problem. Once the immunity is down, yes, we will get the disease with all the symptoms. The government of India has introduced, as Manoj sir was saying, TB elimination program means less than 2 in 10 lakh. So that should be one. With this target in mind, that by 2025, with this target in mind, all the districts in India are working hard to achieve this goal. And this TB elimination program, National TB Elimination Program, is now monitored by PMO itself. Every week, Saturdays, PMO is directly monitoring this TB elimination program. The first is that I'll show you that in the slide. As am I audible? Am I audible?
Yes, yes.
You're audible. Speech is breaking in between. So.
Yeah,
you are generally audible. In between, occasionally the speech breaks. Otherwise, it's okay. We can understand you. We can follow you.
Okay. So without the consulting physician or this goal cannot be achieved in India. Most of the cases, they go to primary centers or first referral units, fever, not resolving fever, cough, lot of antibiotics go. Finally, physician comes in and asks for sputum AFP or now CBNAT, and yes, the patient is having TB. Somehow or other, peripheral institutions are missing the key symptoms of TB. Even if the patient presents with the key symptoms, unfortunately, most of the peripheral institutions miss it. Now, I would like to highlight a few points, very major points only, because it's a vast thing. We have 300 pages books of management of TB. I have taken a few. When I say a few, there are 30 slides or something, right?
It's actually 32.
32 slides. So I will rush through that. Before starting, I would like to share a very happy news that in subnational certification, Ernakulam district has gone bronze medal in India, where from 2015 we have reduced 40% of the cases till 2021. All because of the effort of all the physicians, I would have to say. Most of the cases are being treated by physicians. Complications are managed by physicians. So it has to be a part of the physician. So with this, I would like to start off with the session. So for an overview, India has the highest burden of TB globally. When we say nearly 40 to 30 to 40 crore Indians have TB infection, of which 18 to 36 lakhs, mean should be around 26, are estimated to develop TB annually. On an average, 5 to 10% develop disease within 2 years of initial infection. So the risks are more than 25 times in contacts of bacteriologically positives, 16 to 25 times in HIV, and 3 to 4 times in other immunocompromised patients like diabetes, other drugs, etc. So what they say is if India can reduce the TB burden, the world can reduce the TB burden. So we are number one in that, and even Pakistan is behind us. I mean, better than us in TB. So 75% develop TB after contact with active TB within a year of diagnosis of index TB, and 95% in 25. I mean, in 2 years. So we can see how the disease is progressing. I mean, spreading to the community. So 71% of the household TB contacts of the pulmonary TB have a baseline TB index. That is quantiferon gold index more than 0.35 units per liter. So that is the baseline of quantiferon gold value. Overall, 2% of the household contacts develop incident TB disease. HIV and undernutrition are independent risk factors. The risk of developing TB after PPT is decreased by around 60%, and the risk reduction up to 90% among PLHIVs, people living with HIVs. So what is TBI? There is TB infection, a state of persistent immune response to stimulation by MTB antigens with no evidence of clinically manifested TB disease. So what is the rationale of treating TB infection? Previously, we were not treating TB infection, but almost all might have encountered people coming from embassies for shadows in CXR, chest X-rays, requesting for TB infection. We used to send them back saying that this is not infection. I mean, this is not a disease. Don't worry and all. And even my sister's daughter has been sent back from Australian embassy for this, which after a great Herculean task, she got her travel credentials. So what's the rationale of treating TB infection? There is latent TB. 17% fall in the annual incidence of the case can be achieved by community-based TPT, TB preventive therapy. Effective measures to prevent TB activation of TBI are required to catalyze the incidence of TB reduction. In Kerala, prevalence of TBI was 22.47% among the adult population in a district in an unpublished study. Due to confidentiality, I can't disclose the district and the study, but from government sector, the study was made. Increasing age and history of contact were found to be associated with the TB infection. Focus on high-risk groups like household contacts and old age population. So we have a strategic plan from 2017 to 2025. That is, by 2025, it should be NTB. So the plan is detect, treat, prevent, and build. So this is a cascade of care approach to the target population. It should be in a systematic way. As we can see, target population is there, contacts of TB. So first thing we have to do is rule out active TB. Any contact of a TB patient can be considered as a presumptive TB patient. So we have to test. Once TB is confirmed in that patient, we have to start the treatment, TB treatment, and a systematic follow-up has to be done. But once the active TB has been ruled out, we will have to test for TB infection with IGRA as per our Government of India policy. And if tested positive, he has to be evaluated for TPT. When we say evaluation, what are things are to be evaluated? I'll come in my following slides. After evaluation, TPT has to be initiated, and a systematic follow-up has to be done. So TPT will be for 12 weeks. In pediatrics, it's a daily regimen with rifampicin and INH with appropriate dose. And in adults, it is rifapentin for Kerala and INH weekly once for 12 weeks. So this is a slide showing dropouts at each stage of our scheme. So we are intended for screening 100% of the population, but only 71 to 72% get tested and get referred. 56% get referred if tested positive. And of them, 43.7 get complete medical evaluation for TPT, and 35% get recommended for TPT, and only 30.7%, that is 30% accept and start treatment, and only 18.8% complete the treatment. Some books say at least the latent TB person should have completed 80% of the treatment. So who are the target population? People living with HIV plus ART, adult and children more than 12 months. So infants less than 12 months with HIV in contact with active TB, household contact below 5 years for pulmonary TB patients. So for them, the strategy will be TPT to all after ruling out active TB disease. So this ruling out process is all among our esteemed physician. To rule out active TB and to start. Household contacts 5 years and above for pulmonary TB patients. TPT among TBI positives after ruling out TB disease. Chest X-ray and TB testing would be offered wherever available, but TPT must not be deferred in their absence. So when we expand the risk group, so who are involved in that? Those on immunosuppressive therapy, having silicosis, on anti-TNF treatment, those on dialysis, prepare for organ or hematologic transplantation. So TPT has to be given after ruling out TB disease among the TBI positives. So TB disease has to be ruled out before initiating TPT among the TBI, TB infection positive patients. So this is something regarding tuberculin skin test and IgRA. somehow I wanted to say this because quite a few man-2s are coming, but we are not getting the standardized PPD for that. So specificity is low in BCG vaccinated people in skin test. Sensitivity is high and it's easy to use, but interpretation is a bit complicated. Cost of test is very low and manufacturing is complex old product, and now standardization is not there. Previously they used to prepare standardized PPD at Serum Institute Gindi, Chennai, but now no, they are not preparing the standard thing. So what are the benefits of in special population children and no, that's a different thing. For IGRA, high on BCG vaccinated, if the TB infection is there, specificity is high, sensitivity is also high. For ease of use, yes, we need labs and infrastructure. ELISA reader is necessary. So we get antigen coated test plates, which is there for 22 patients. If you don't use the 22 samples, that plate will have to be discarded after the single use. So there will be a financial loss to the lab. So even we have to wait for 22 samples. Cost of the test is a bit high, but still we are managing. Manufacturing, yes. And among children, TST is affected by young age, and IGRA is also affected by young age if it's not done properly. PLHIV, HIV status for correct interpretation is needed, and IGRA affected by HIV and low CD4 counts. So when we start TPT, before starting TPT, what are things we have to think in mind? There is contraindications of TPT. So active TB has to be ruled out. Acute or chronic hepatitis has to be ruled out. Concurrent use of any hepatotoxic medications, nevirapine like that. If the person is on regular and heavy alcohol use, peripheral neuropathy has to be ruled out. Hypersensitivity to any of the drugs, rifampicin, rifapentine, or INH has to be ruled out. Yes, this is what I was telling. Before starting TPT, we will have to discuss with the patient and the bystanders what is the rationale of TPT, because it's a new thing and people are healthy and we are administering drugs on a apparently healthy person who turns out to be positive for latent TB. So rationale for TPT has to be informed to the patient. That is how it is protecting him, household contacts, and the community per se. Rifapentine is available only under NTP right now in Ernakulam district. So the drugs are free under NTP program. As almost all our physicians are aware that Ernakulam is the first district in India to provide government drugs to the hospitals, if required, through STEPS, System for TB Elimination in Private Sector. Once the STEP center in your hospital informs us that they need, a poor patient is there, they need our drug, we do supply to you. The patient is yours, investigations are yours, admissions are yours, but the drug is supplied by NTP. But for TPT, we have not started it. We are negotiating with the government for that. Hope for the best, we'll see. TPT duration and the follow-up has to be discussed with the patient, and possible adverse drug reaction also has to be discussed with the apparently healthy patient. Importance of completion of TPT, signs and symptoms of TB disease and what to do. So during the TPT, the patient may develop TB disease also. So then there is no point in continuing TB disease, and the patient has to come back to us, and we will have to evaluate the patient and start the TB treatment and send the sample for line probe assay to know whether any resistance has developed. They should have the contact details of NTP key staff, that is senior treatment supervisor, senior treatment lab supervisor, TB health visitors. So at any given point of time, they can contact them, these NTP key staff. They have been provided with the free mobile numbers and tabs. So anytime they can be contacted for genuine issues. And one more thing is like we should involve the family members and caregivers. Like if we don't involve, they won't be knowing whether this patient is having latent TB or not and why he is consuming medicines. As a lot of things are coming out against modern medicine from all sects. So I think family members also need to be counseled for the TPT of the patient. So what will be the common adverse drug reactions? What happened to this? This is the previous slide only. Okay. So what is the pre-treatment evaluation we should do? Personal history like allergy, hypersensitivity to rifampicin, rifampicin, rifabutin, HIV status, ART regimen, pregnancy status, birth control method, comorbidities, malnutrition, diabetes, chronic liver disease, drug history, ARVs, opioids, antimalarials, interaction with TPT. They interact with the TPT. But LFT is routine baseline. LFT is not recommended usually, but in risk group, especially like a history of liver disease, alcohol, HIV, pregnancy, immediate postpartum period, we ask for LFT. So we have to assess the social and financials of the patient to overcome the barriers for completion. That also is a factor that we have to assess. So this is the TPT regimen state policy. PLHIVs and children living with HIV, 6H has to be given daily. IGRA test is not required. For household contacts less than 5 years, daily 3HR is given. Again, IGRA is not required. But households contacts between 5 and 15 years, 3HR daily has to be given, and IGRA has to be done before that. Again, for household contacts more than 15 years, 3 HP is given, and IGRA is required for that. For other groups, risk groups, 3 HP or 6H is given. So what is this 3 HP regimen? 900 mg of H and P. It's a weekly dose, 12 doses, 9 pills of loose drugs or 3 pills of FDC on the day of intake, taken after meal, pyridoxine to all if available, and must for severely malnourished and severe alcoholics. If pyridoxine is not available, even a good B complex preparation also will suffice. And again, for rifampicin, safety data of rifampicin is not available for pregnancy, so 6H is preferred. So advantages of 3 HP regimen is better adherence due to shorter duration, almost 20% more completion rate. We can see. Previously for household contacts, we used to give INH and it's a daily regimen and all. So people used to skip and it was 63%. Now it is 80.7% or something. So this is the regimen for treatment for LTBI among eligible individuals. INH plus rifampicin for 3 months, age group 10 years and older, rifampicin age 10 years and older. So in pediatric age group, we'll be using rifampicin. So this is the weight band for kids. So it's not a stable amount, but for different weights, it goes by as weight increases. Weight increases, the dose of drug also increases. So post-treatment PLHIVs and CLHIVs, those who have successfully completed the treatment for TB disease earlier should receive a full course of TPT after completing the treatments. So before coming to role of pyridoxine, one slide which we missed that has been came out. What are the possible adverse reactions we could encounter while going in for a TPT for a TBI patient? Fever could be there, unexplained anorexia, coffee or cola colored urine will be there. There can be stress, skin rash, persistent paresthesia of extremities, persistent fatigue or weakness lasting for 3 or more days. There can be abdominal tenderness, especially in the right upper quadrant. Easy bruising can be there. Arthralgia can be there. And nausea, vomiting are the common adverse reactions we have encountered so far. On this slide, the role of pyridoxine, why I have kept is like we are getting a lot of neuropathies and all. So I have kept this slide. So in fact, peripheral neuropathy is there. Symmetrical numbness and tingling in extremities. We should give it in risk groups, especially this alcoholic dependence and HIVs, malnutrition. HIV is there, renal failure, diabetes, pregnant and breastfeeding. Withdrawal of INH and high dose of pyridoxine is recommended. INH and high dose of pyridoxine has to be given in some cases. As prophylaxis, in children, 10 milligram per body weight, milligram per kg body weight per day. Adults, 25 mg per day. PLHIVs, it should be 50 mg per day. This I have already told. So this is something we will be worried when we give rifampicin and INH. So for emergence of drug resistance, so far there is no evidence for drug resistance with TPT. Ruling out of active disease is very important before giving TPT. Rapid DST if TB detected before, or rapid DST has to be done if TB detected before, during or after TPT. That is drug sensitivity test. we have that CBNAT. CBNAT not only detects TB but also detects the rifampicin resistance, not rifampicin sensitivity. What it gives is whether the sample is rifampicin resistant or not. Safe in special situation, safe in pregnancy with 6H only. INH and rifampicin are safe. Rifampicin data we don't have. Can be given INH and rifampicin. Rifampicin can be given in antenatal. Rifampicin can be given in antenatal and postnatal period. Women on OCP, the interval of replacement should be decreased to 8 weeks from 12. Liver diseases, caution if baseline transaminases is more than 3 times, differ in end-stage liver disease, differ till active illness is solved in acute hepatitis, 6H tolerated in chronic hepatitis B and C. Renal failure, safe to use. Severe renal failure, pyridoxine has to be used. Babies born to mothers with TB disease. If baby is unwell, pediatric referral must. Ensure treatment for mother and infection control. If baby is well, TPT may be provided. BCG vaccination should not be delayed, even if TPT is given. Pyridoxine 10 mg per kg body weight per day during TPT and while on mother's treatment if the baby is breastfed. If the baby is breastfed, pyridoxine has to be given to the baby. HIV exposed and patients on nevirapine 6X can be safely given and breastfeeding can be continued. So how will regimen? It's preferable to take TPT under 3HP regimen under direct supervision of health worker. If not, establish strong adherence mechanism with the family and the treatment supporter. Audio or video call weekly on the day of intake. It's something like dots only. So it will be preferable. And what we do is we do a video call to the patient, especially to adults, because they can easily forget the weekly one's drug and our goal will not be achieved. We'll be providing them the treatment card. There will be documentation in TPT register at each and every TU level, and once monthly clinical follow-up will be there by the medical officer, tuberculosis control, and the PHC medical officer. With all these cases, with cards, we attach a clinical evaluation form. There is a fortnightly clinical evaluation. So how will we manage an interrupted case? No, that is not included. That we have to bring the patient back to TB center where we have a committee. So we will have to evaluate and restart it. So all the interruptions should be referred to district TB center, or we have a second committee at Government Medical College, Kalamashiri, under Dr. Anjita Tilagan, Professor of Respiratory Medicine. So we will have to evaluate. So the one with the district TB center has all the consultants from General Hospital, and Manoj sir also is there. So summarizing the systematic screening for eligible population for TPT and active TB, complete cascade of care with the active TB and IGRA, CTB for TBI. CTB has not come so far. CTB is a skin test. Government of India is planning to introduce that. We have not been given any much details about that or training about that. So I don't think I am qualified to speak about CTB. CTB is soon. This year only CTB has to come. Reduction should be given at least in high risk group. Respect patient's decision. We have a lot of patients who were not willing to take TPT? Because I'm apparently healthy, why should I take the drug? Especially the one which has brown or cola colored urine, it will cause a lot of problems. So we will have to respect the patient's decision. So follow up the patient. If he develops symptoms, test him for TB. If positive, we'll start off the treatment. So we will have to individualize the monitoring plan also. So once monthly monitored dose has to be given to the patient. Once monthly, we have to examine the patient for any ADRs. So each and every patient, it has to be different. So some won't like going to their house, some won't like me calling them, some won't like me doing a video call while they are consuming the drug. We will have to monitor the adverse events, drug interactions, and activity. Complete this I told. Complete at least 80% of the expected dose. Thank you.
Thank you, Dr. Sharath, for your elaborated talk. I think the subject is open. Many will have many doubts.
I have reduced quite. I have cut short quite a few things, and I had sent the elaborate list to Manoj sir. But 1 hour was there, so I had to limit to that. So major things I told. I think. Manoj sir, എന്തെങ്കിലും കൂടുതൽ പറയാനുണ്ടോ ഇതില്?
I have a doubt.
എന്തോ?
I have a doubt.
പറയൂ sir.
You are told the patients can develop active TB disease at any time during this TPT. How will you follow up, whether by sputum examination or chest X-ray? How often you suggest that?
Sir, latent TB infection means the patient won't show any symptoms. I was telling throughout that apparently healthy patient. So once the patient develops porous, 2 weeks duration cough. I mean, we used to see we used to do 2 weeks duration cough, weight loss, fever, evening rise of temperature, chills. We used to screen for TB. But any patient developing any of these symptoms in the midst of this TPT, we have to screen the patient using CBNet. I would suggest to go for CBNet. If CBNet is not available, we can go for our usual routine microscopy. Now the government policy is to migrate all the microscopy to molecular testing, that is CBNet or TrueNet. And of course, chest X-ray also, previously they were not willing for chest X-ray, but now the policy has changed. Whenever the chest X-ray is available, that can be used as a primary tool. And what they say is for such patients, any contacts or any patients, any shadow in the chest X-ray can be considered as a suspected TB patient, presumptive TB patient. So they have to be evaluated.
It is the custom that before starting ARD treatment, you should screen for active tuberculosis disease. If the patient is not having active tuberculosis treatment, should we start TPT and wait for 12 weeks before starting ART?
Before starting ART, yes, we have to start the treatment.
So give TPT for 12 weeks.
Yeah, give IPT along with what do you call ART.
Is it possible?
Now this system is, I am the 8th standard officer also. Now the system is we are starting IPT along with ART. The only thing is people are resistant. എത്ര ഗുളികയാണ് ഞങ്ങൾ കഴിക്കുന്നത് ഇത് കഴിച്ച സൈഡ് എഫക്റ്റ് വരില്ലേ and the basic thing what we tell me and Parvati ma'am, what we tell is like see, this is the tablet we are giving to kids, so you can take, it's not a big tablet. And Ernakulam is one district in India which has more than 80% IPT in ART treatment.
Sharath,
Government
there is a-
IGR is available only at Kalamassery.
Allala, IGR is available at Kalamassery, IGR is available at Muatupura, IGR is available at our public health lab. Actually, that should have been at Ernakulam General Hospital, but some, political administrative issues shunted that thing to public health lab.
Okay.
And without one lab technician, they won't do the test there. And they won't give the ELISA reader to us also. So this is the thing.
Any
And-
other doubt?
Very informative talk, Dr. Sharath. Congratulations. And also, you achieved the bronze medal for the Ernakulam district for in the effort to eradicate tuberculosis. I have one doubt. You mentioned out of the latent tuberculosis infection, only 30% accept the treatment. And even out of them, only 18 to 19% complete the treatment. So how far is it going to be effective in eradication of tuberculosis? I shall repeat the question. You mentioned only 30% of the LTBI cases accept the treatment for TPT. And out of them, only about 18 or 19% will complete the treatment. So isn't it quite ambitious that the government's effort to eradicate tuberculosis by 2025? Are you optimistic or are you planning some other alternative plans?
So this we have rolled out. When I joined Ernakulam in the year 2016, we had around 3,900 cases in Ernakulam, and now it has come down to 2,740 cases as of December 31, 2021.
Yep.
So it was a series of effort, starting from Ayurveda, homeo, medical shops, laboratories, everywhere. We had gone to each and every place, and we got a very good welcome from private hospitals. In Ernakulam is the first district to provide government drugs at private hospitals for their patients. So, sir, as we go ahead with this, we have to plan. There is no other go. Unlike Uttar Pradesh, Anup is here. Anup was telling that 70,000 population in UP are being given TPT. So I asked how. So WHO consultant Dr. Gayatri was there. Her counterpart was there. She's also a Malayali. How? We just give TPT to all the people, or all the contacts, HSC of household contact of TB patients. So we are giving in a rational way. We are testing and giving. So we will have to achieve. There is no other goal. One.
Right.
And second thing is, the main thing, whenever we say it's an eradication, it's not an eradication, we are saying, elimination we are saying. Eradication is only smallpox has got eradicated. Elimination we are saying, there is less than 2 per 1 million. So cases will be there. The burden to the patient and his family are grossly decreased.
Thank you, Dr. Shah. In fact, I got one more doubt. You also compared the Manoj test versus the IGRA. You compare the Manoj test versus IGRA.
Yes, sir.
And you find with that slide, it appears that Manoj test is of no use now. But however, a lot of physicians continue to advocate the Manoj test to screen out tuberculosis. What is your opinion? Should we eliminate the Manoj test altogether? Should we resort to only IGRA?
You expect an answer from a clinician or a program manager?
I feel we should not do Manoj test at all. That's my opinion. I generally have been advocating to people also. Don't waste your time and effort on Manoj.
I will answer in both ways, sir.
Yeah.
As the programmatic management, we have to go by IGRA, because there is no standardized PPD available in India. As you know, IGRA is in government sector, of course, it's free. the least IGRA quotation we could get was from a lab for $1,000. So if 4 people in a house, they go to a private hospital, private lab for IGRA, this specific lab, which gives for 1,000 rupees. So 4 persons in a house, it's 4,000 rupees. It's a huge amount for them. And some corporate hospitals, each IGRA costs around 3,500 rupees per test.
So there are practical problems.
Obviously, MAN2 will be in use as far as we get good induration and redness. Even if there is no standardized PPD is available. But what program says is we should completely avoid MAN2 test.
Yeah.
But whatever it is, MAN2 should not be used for diagnosis of TB. That is what the program says. Even IGR also is for not diagnosis of TB disease. It is for diagnosis of
Infection.
TB infection.
Thank you, Dr. Sharath. But once we diagnose infection, we are like duty bound to treat also. So
Sir?
once we detect the infection, then we need to give the patient TPT, right?
Yes, sir.
And that's
Yes.
our responsibility.
Yes, sir.
Thank you, Dr. Sharath.
If no more doubts,
Oh, I guess there is no more doubts. Maybe you can wind up, Dr. Manoj.
yeah. Thank you, Dr. Sharath, for your
Thank you,
elaborate.
sir.
And on behalf of API Cochin, I thank you once again. Thank you.
Thank you.
So much for giving a very useful talk from your side. We are all indeed definitely benefited, and we have come to know that how much effort you're putting into this tuberculosis program, the National Tuberculosis Program. Thank you so much.
Okay, sir. Bye, sir.
Bye-bye. So this, I conclude the session. Good night.
Good night, sir.